Hello and a warm welcome to you all. Those of you who are joining us from India, as well as those of you who are joining us from the Middle East. Thank you for taking time out to attend this webinar that is presented by The Week and the Medi Q Healthcare Group. The Week, as you all know, is India's largest selling news magazine in English. From its inception in the year 1982, The Week, practicing journalism with a human touch, has always stood out for its concept and content, adding to the literary legacy of the Malayalam Manorama group. The Week's association with the healthcare industry dates back to the time it started its Best Hospitals survey. Since 2004, the survey is published annually as a special issue in the Week magazine, and since then has been receiving tremendous response both from our readers as well as from the healthcare industry. We also have engaged with many healthcare groups across the country to bring out regular features, campaigns, webinars, and events related to healthcare. So this webinar today, which focuses on sustaining affordable quality healthcare in the post-COVID world, has been organized in collaboration with a knowledge partner, Medi Q Healthcare Group. And as you all know, Medi Q Healthcare Group is a Dubai-based company that provides comprehensive healthcare advisory services. They help organizations plan, build, and operate healthcare centers in a cost-effective manner globally. They are amongst the first companies to partner with the UAE government in its fight against COVID-19. They specialize in COVID field in hospital infrastructure, COVID clinical operations and management, COVID research and optimization protocols. They've designed, set up, and operated 6 COVID-19 field hospitals with critical care in and around Abu Dhabi in the UAE. Their operations were awarded for speed, cost effectiveness, and operational efficiency. When the COVID-19 crisis was at its peak last year, when it affected all of us, Medi Q Healthcare Group partnered in designing and constructing a 200+ bedded COVID-19 field hospital in Abu Dhabi in a record 9 days, which is immense. The group has experts for cost management, healthcare operations, as well as supply chain management across the world. So today's webinar on sustaining affordable quality healthcare in the post-COVID world comes at a crucial time, when we are all undergoing the COVID pandemic, has been disrupting hospital operations across India and the world. We've all witnessed the time when elective procedures were cancelled or postponed in order to prioritize hospital capacity. And hospitals were striving hard to ensure the safety of their patients and of the medical staff. Concerned about potential exposure to infection, patients had been limiting their hospital visits as well. And this is especially important because this in turn led to a sharp decline in revenue for many hospitals. And then many hospital institutions, healthcare institutions and hospitals initiated layoffs, furloughs, and salary cuts to contain costs and maintain financial viability. It is in this scenario that this webinar becomes truly important. And at such times, what mechanisms can hospitals put into place in order to ensure financial sustainability in a post-COVID world, while not compromising on the quality or affordability of its healthcare delivery? We have today eminent leaders from our healthcare institutions and hospitals across India and the UAE to help us understand this aspect better. They will share their experiences, the lessons they've learned during the pandemic, and their plans to make healthcare affordable as well as profitable for everyone in the post-COVID world. So let me begin the webinar by calling our first panelist, Dr. Kovalamudi Hariprasad. He's the president of Apollo Group of Hospitals. Welcome, sir. Dr. Hariprasad, you require no introduction. He is a cricketer turned doctor turned pioneer of emergency medical services in India. Dr. Hariprasad has excelled in whatever he has ever set his heart upon. As a cricketer, he went on to become one of the youngest Ranji Trophy players. Yes, you heard that right. He went on to become one of the youngest Ranji Trophy players to represent Hyderabad. And then he gave it all up to pursue his career in medicine He joined Apollo 23 years ago at the insistence of Chairman Pratap C. Reddy. And very interestingly, Dr. Hari Prasad has also written a book titled I Am Possible. This book engagingly captures the story of his eventful journey so far. His book, which became a sensation, it went into a third reprint on the very day of its launch. It captures the essential predicament that has followed him throughout his life. Whenever things would seem settled, the earth beneath his feet would move. It's a compelling read indeed. Welcome, Dr. Hari Prasad. Sir, if you could give us an overview on the cost challenges that lie before healthcare providers post-COVID-19, and also how did Apollo, a renowned global hospital chain, navigate through the crisis? Over to you, sir.
Good evening, and as was Pooja introduced, I used to play competitive cricket very early in my life, and I was an opening batsman at that point of time. And today I again get an opportunity to open this seminar as an opening batsman. And as all of us would realize, the tone set by the opening batsman often dictates the rest of the seminar or the rest of the match or whatever you're doing. If you find the seminar useful, then give me all the credit. If you really don't find it useful, then the credit goes to all the rest of my panelists, which include a lot of familiar faces like Harish and the rest of them. Probably COVID is the most spoken about and written about subject for the last 18 months. It's never gone out of our minds. A lot of things have been said and written about COVID. And while we were reading all these things, some of which were facts, some of which was not really facts, and was not necessarily the right thing to say or write, something very interesting happened, which I don't know how many of you would have really paid attention to. COVID really struck us. The first wave struck us in the first quarter of the last financial year, which in India's context is April to March. So it struck us in the first kind of quarter of the last financial year, and it was mayhem. All the listed hospitals reported heavy losses. Many of the smaller hospitals, clinics, everything shut down. They were all literally closed because they were scared of the virus. But when the second wave struck, it was this first quarter of the current financial year. And if you actually see the results, financial results reported by the listed entities, all of them reported good profits, a turnaround. And we, being in the market, know that a lot of smaller hospitals have actually opened up and have started to do well. So what is that changed between the first wave and the second wave? For sure, the virus had changed. While China apparently contributed to the birth of the virus, India did its bit by contributing to the delta part of that virus. So the virus for sure changed. But one thing which improved was our understanding of the virus, the way it behaved, the way disease progressed. And we had a better understanding, so our responses were better to protect not only the patients and the community, but to protect the healthcare workers themselves, which was a very important part of managing COVID. The fear of healthcare providers reduced because of the better understanding. And this is one of the factors which I feel contributed to a turnaround in terms of being available for providing care, and then the rest of the things followed. There were more therapeutic options which are available, and be it I don't know which worked, which did not work. There's a lot of things being said. We still do not have a definitive drug for treating COVID, but remdesivir, steroids, and whatever were used, they obviously worked because our results show that we did much better than most of the world in terms of our outcomes. And then what started off as a single lab for testing went into a few hundreds of labs across the country. So the testing facility improved in the country. So more and more people got tested. The earlier you were diagnosed, the earlier you would be isolated. So the lesser chance of actually spreading the virus. So the testing facilities improved. And if all the people who were testing positive had to be isolated in a hospital room, as happened in somebody's on, needs to go on mute. Mrs. Lalita Sharma, yeah. So the testing isolation, if first wave, most of them actually were so scared that they were isolated in hospital beds. But now in the second wave, many of them had other options of isolation, including home isolation. There were hotel rooms created for isolation. So a lot of other things came up. So the burden on hospitals and healthcare infrastructure reduced because of these options. Then we had realized very soon that this COVID was not the 14 days or 21 days during which the patient was positive. The after effects of COVID were significant, which needed him at a tremendous amount of care. So the COVID rehab program started taking off to reduce the morbidity and mortality. And again, there was the second wave actually turned really deadly because a significant number of people actually went on to ECMOs and needed lung transplant, and it became much more complex, and the need for critical care increased significantly during the second wave as compared to the first wave. Now, in the midst of all this, technology took over, starting from a simple teleconsultation to an EICU to e-radiology, telepathology, whatever. Technology took over in a big way. And once technology started taking care of the therapeutic options or the clinical options, the natural offshoot was a better data collection and availability of data, better quality of data. And this started manifesting itself in the form of artificial intelligence. Today, we have a number of options which are available to us, which are coming out of this artificial intelligence platforms from different parts of the world. And then the vaccine. The vaccine, as all of us know, and we in India are really proud of, we managed to produce our own vaccines, and probably we vaccinated the highest number of people in any country, although the proportion of people to be vaccinated is still high. But we have vaccinated a significant number of people. And we did a study within our own hospital amongst the healthcare workers and found that amongst the healthcare workers who were vaccinated, the number of people who needed hospitalization after turning positive was less than 1%. And there was absolutely no mortality in these patients. So the vaccine does work, and the vaccine created a major source of security especially for the healthcare workers to take on the responsibility at the bedside of a patient who is infected with COVID. And the lockdowns changed. First time it was a blanket lockdown across the country where people could not move out and there was no travel. While this time it was more scientific, and the hotspots were identified, and people outside the hotspots could travel. So we actually saw during the first wave absolutely no non-COVID patients coming into the hospitals. Even emergencies, we saw people dying of MIs and strokes at home because they were scared of coming into the hospitals and because of the lockdowns. But now this time, during the second wave, we did see the patients into the hospital significantly reduced in numbers, but we did see the trickle of patients coming into the non-COVID patients coming into the hospitals. So that kept the non-COVID work going and not completely shut as it was in the first wave. And then the costs, all the hospitals realized that we needed to deliver more for less. That was one thing which became very, very apparent. And all the hospitals, wherever I have spoken to colleagues across the sector, cost saving became a big, big factor across the industry. And that was aided by multiple things, including the Prime Minister's Atmanirbhar Bharat, because a PPE set which used to cost an X amount of money for in the first wave came down significantly and cost about a fraction of what it used to cost in the beginning. So there were multiple other things which were brought in. Price caps were brought in, and including on medications and drugs and consumables. So that helped in bringing down costs, and a lot of other expenditure was controlled. And if you actually, I did not know that there were so many cost lines which existed in a hospital. So once we started looking into the cost lines, we really understood where we could save on without really impacting the quality of care for a patient. And I would encourage people to actually go into normally we look at it in a very broad manner and don't look at it in a line-wise way. I suggest and recommend that you look at it item-wise, line-wise in your cost sheets, and you will find that you are actually capable of saving a lot of money in treating the patients and in running your services. And what it is also demonstrated, though the healthcare system was really overwhelmed, there were real shortage of essential things, including oxygen. A lot was said about it, but the healthcare sector actually demonstrated a lot of commitment and dedication to respond to the epidemic with resilience. That is the most important part of it. And all the stakeholders, the patients, the providers, the community, and the shareholders contributed towards this. And I think it is this partnership which was very, very critical when it comes to managing a critical situation like this. And I think it came in well together, and we've learned a lot of lessons, and I guess we are better prepared. Although now we heard that the WHO saying that it has probably become an endemic in the country. And I really hope that the predicted third wave doesn't come in, but I would really want you all to think about the prediction if a third wave does come in, and if children are really the major targets for the third wave, how bad it would be for all of us, because isolating an adult itself is a challenge. I'm just throwing up one challenge which you would see. Imagine isolating a 6-year-old guy. How are you going to isolate him? What are the other things which you would need to do to isolate a 6-year-old child? So it is, and as an adult, I would feel that I would rather suffer rather than my child or my grandchild suffering. So it's going to have a huge psychological impact. And the only way all of us know to prevent a third wave is to get vaccinated, make sure everybody around you is vaccinated, and make sure that all the precautions are taken. And I would really pray and hope that the third wave doesn't set in. With this opening, I really hope that we have a good session. We have some very exciting speakers ahead, and I hand it back to Pooja right now.
Thank you, sir. Thank you so much for such an insightful overview and for really putting down aspects in which we can take care to prevent the third wave from coming in. Our next panelist, I would like to introduce is Dr. Harish Pillai, CEO, Aster India, Aster DM Healthcare, a doctor with exceptional leadership skills, an expert in hospital administration, quality, brand management, business strategy, product launches. And Dr. Pillai joined the Aster DM Healthcare Group in the year 2013. His ability, joint ventures. Dr. Pillai has played a significant role in the development of the healthcare industry to strategize and manage large-scale healthcare organizations, helped Aster MedCity consolidate in India and the Middle East, North Africa. by setting new benchmarks in quality, its place among the top hospitals in the country in a span of just a year. And patient care. Dr. Pillai, I would welcome you to the webinar and want to ask you, since Aster works in two different geographies with completely different business environments, could you compare what exactly are the cost challenges in these two markets? What is the difference between Dubai and India, both in terms of COVID and post-COVID context, please? Thank you.
Thank you, Pooja. So comparing Dubai with India is like comparing chalk and cheese. It's two big, huge differences.
Right.
Number one difference is that in terms of the payers, it's they have a very interesting history that late 2000 itself, Abu Dhabi, the capital of UAE, had already adopted a DRG model for all its residents. It's 100% insurance. Whereas in 2020, Dubai decided to roll out a DRG-based insurance model, which means that it's basically bundle care, diagnosis-related groups. So for a set of patients with similar kind of ICD coding, we have an international classification of diseases. Right now we use ICD-10. The reimbursement is exactly the same, which means that there is a huge amount of pressure for hospitals to be extremely cost efficient and also get their clinical algorithms right. So you can imagine that if you have 5 doctors in a clinical unit, the 5 doctors might have the same diagnosis, but there will be subtle differences in the approach to medicine. But an external environment like a DRG enforces a sense of discipline to be very, very sensitive in what are the bundle of services a patient can get into. The fallout of that is most hospitals in that kind of an environment are under pressure to improve their bottom line. Margins are a challenge. Top line growth is extremely conservative. We are talking about low single digit growth from a CAGR point of view. So most folks have to focus on bottom line growth by bringing in this kind of a system. So the good thing is that because of these kind of pressures, most hospitals have invested in first generation hospital information systems, which most of us in India can't afford because India is clearly a totally different market. So this ability of the first generation hospital information systems to give you that kind of coherent 360-degree dashboards brings in that kind of efficiency where the clinicians and the non-clinicians work in harmony together for the benefit of the patient. India, at least I can tell you from the context of my organization, we are located in 5 states. So if you look at the state of Kerala, where we are the largest providers, in the city of Cochin itself, the payer mix would be 70-30. 70 would be cash out of pocket, and 30 would be different forms of credit. In that bundle of the 30%, you will have a share of TPAs and insurance, and then you would have a small element of government schemes and other players. Whereas if you come to the Bangalore market, where we have a significant presence, it would be somewhere around 60-40, where 60 is still out of pocket and 40% would be cash. So one prediction which I see in the Indian context, especially post-COVID, is that the Indian middle class family, like we like to call the Aam Aadmi, right, in our context. So people have really realized that you cannot afford to imagine that our traditional cultural sense ki ye mere saath kabhi nahi hoga. That's the kind of a fatalistic attitude that something bad would only happen to the neighbor or some kaka kaki somewhere far away, but never to me and my family. So that has changed, thankfully. So people are willing to set aside their family budgets and go for private insurance. I see, and you can already see the trends. If you look at some of the top insurance players in the market, the kind of non-life insurance uptake has been massive in the past 2 years. And that trend is going to go. And I see in a 4-year window, when you look at India in 2025, the percentage of out-of-pocket expenditure in healthcare in India is significantly going to come down due to a combination of course, Aishman Bharat takes care of the BPL category, and of course, there is a massive growth in private insurance. So broadly speaking, this is the macro differences between UAE, specifically Dubai, and India from a payer kind of a point of view. picking off also a point from the opening batsman, Dr. Hari, it was a wake-up call for all of us as providers, thanks to the shock, I would say, to the system in quarter 1. Many of us administrators, we were trying to focus on how do we survive, because it was imperative that we all exist. If we don't exist, how do we tackle this kind of pandemic? So existence for a provider is to really look at cash flows. If you can have a viable cash flow scenario, then you can afford to pay your staff, you can buy the materials required to take care of. So that was a really important thing. So many of us were looking at our P&L statements. We were looking at direct cost and indirect cost, and did all kinds of things, including tightening of our belts to look at when is the end game. Please understand that in April 2020, we didn't know that the lockdown is just 3 months. Nobody could predict that how long the lockdown is going to be. So it was an interesting experience. But I'm happy to say I also totally echo with what Hari mentioned, that many of us, the lessons which we implemented and absorbed in quarter 1 helped us in quarter 2 when there was a phase withdrawal of lockdowns. And then we looked at this hybrid management of COVID as well as non-COVID workload. By quarter 4, it was almost back to normal. Wave 2 was completely different. Wave 2 was pretty aggressive. There was an extreme stress on our resources. Like, who would have imagined that a country as large as ours would be really looking for oxygen supplies? Liquid oxygen was worth its price in gold. There was this huge pressure on intensive care beds. Of course, thankfully, the human resources element, because we all had undergone the first wave of vaccinations already this year. So that was, at least that shield was already available. But the stress of managing the second wave was extremely challenging for all of us. But from a fiscal point of view, I think Indian healthcare has benefited from this kind of experience. One observation.
On our next panelist, Mr. Devendra Singhvi, Group Chief Financial Officer of Saudi German Hospitals in the UAE. Mr. Singhvi comes with an experience of over 2 decades in the healthcare domain, ranging from pharma to clinical trials to healthcare delivery. He's responsible for the overall financial strategy and direction at Saudi German Hospitals. He guides the company's aggressive growth, and also had added interests in big data and how it's evolving the corporate landscape of the world. Before joining SGH, Mr. Singhvi held previous CFO roles at CK Birla Hospitals and Biogen Idec Inc. He also worked in oil and gas and FMCG sectors. A chartered accountant, Mr. Singhvi has throughout his career established a reputation for building world-class teams and for aligning financial and business metrics to support business strategy and high growth. Mr. Singhvi, welcome on board. Ask you, at a time when elective procedures got cancelled, or even postponed in order to prioritize hospital capacity for COVID-19 care, how did Saudi German hospitals, which are known for their premier services, sustain the financials? Also tell us about how the UAE market is as a market and as an investment opportunity. Over to you, sir.
Hi, very good afternoon to all of you. This is Devendra Singhvi. I'm the Group CFO for Saudi German in Group UAE. Just because it's Saudi German in the Middle East sector, I'll just give you a brief about Saudi German in a couple of minutes. It's a 35 years of track record. Saudi German Group has around 12 hospitals and multiple clinics across Middle East. All the hospitals are JCI accredited, and we have 14,000 employees, a turnover of around 2.8 billion in financial year 2020. And overall, currently, even after COVID, we have 5 new hospitals which are under construction. And we have partnerships with Mayo Clinic and other big partners. And we have overall geographic presence in Saudi Arabia, Egypt, UAE, Yemen, Morocco, and Pakistan. And we have around 12 hospitals plus 5, as I told you, is new coming up. And we have a credentials, we have tie-ups with Arab Fund, Fin Fund, International Finance Corporation, etc. Now coming to the overall, what we talked about UAE as a market, you can see UAE, the healthcare spending in UAE is around 4.8% compared to India, which is around 1.3 percentage to GDP, so which is quite high, but when we compare to European standards, it is still quite low and there is a lot of scope there. And when we look at what's the growth which is there, it's in the last few years, the growth has been quite low, 2.2, but we expect very good growth of around 7.5% in the future, which I'll come to you what's the reason for that. And there is also good potential to increase the bed density here, which is again at it's compared to the others, it is 1.4. And overall in the middle, it's less. Right now, coming to, I think so. I'll take first from the investment side. What's the benefit of investing in? What are the opportunities of investment in UAE and Middle East? Recently, what has happened in the Middle East post-COVID is a lot of visa regulations have been relaxed, and investment regulations also has been relaxed. What I mean is, earlier, the visa was quite tough to get, and then there was every 2 years renewal was there. Now they have come up with good. There is a 10-year golden visa, there is a silver visa, then you have work from home visa, there is a visa for old people. That means what it will do is the floating population which was there, which will go down, and we will have a lot of increase in the population. And when it increases, the age group also will change. And once the age group changes, you know that it will impact the healthcare. Because currently it is a lot of young population is there, but going forward with all these changes which are coming, the stability in the country will be there, and you will find more and more shift towards the tertiary healthcare. And parallelly, what has happened is UAE government has also done a lot of changes to the investment regulations for the healthcare. Now there is 100% investment in healthcare is possible in United Arab in the UAE, which is a very good step, and hopefully this will bring a lot of investment. Secondly, medical tourism is a big opportunity here. UAE already ranks 6th in the world in terms of medical tourism, and there is a huge scope given the infrastructure what it has and kind of support government is giving to increase. There is a 2030 plan for medical tourism. Government is supporting a lot, so that will really also help. And thirdly, in terms of opportunities, why healthcare is, there are a lot of lifestyle disease in an aging population. Currently it is low, but we see around 5% of the population will be more than 65 in 2030 and beyond. So that will also add to the future growth of healthcare in the Middle East. And private healthcare spends also in UAE is quite, compared to others, it's around more than 50%. And government is pushing for PPP partnerships like in cardiology, cancer, and others. And all the growth is happening on the private sector, and there are a lot of incentives which are there. And more so, one additional thing is the relationship with the neighbors like Israel, Qatar, etc. has also improved. So that is also adding to a huge investment opportunity. Israel has already invested in healthcare. There are many current healthcare players who have invested with Israel, and there is new investments also coming up. Like Hyperbaric came within 6 months of UAE announcing the partnership with Israel. It was very fast investment and it's up and running. This center only it was in Florida, and second center opened in Dubai. So this is the kind of change which is happening here, which is quite fast and rapid. But having said that, as Harish told, the market is very tough and very competitive because it's a payer-driven market. Payers, and it is off late, DRG has come, which is bundle services. It was in Abu Dhabi, now it came in Dubai. And last week it was announced for rest of the United Arab Emirates also, they are implementing this system, which in 2021 it will come. It will put a lot of cost pressures on everyone and they need to work on it. Secondly, the challenge is the shortage of quality healthcare staff in this region is very, very much. and it's also very expensive. So manpower cost is very high, which needs to be managed. And there is also lack of super specialized care facility, which again is opportunity. And I'll come later how we are doing as Saudi German in this place. And it's a OPD driven market mainly because of the kind of insurance what we have. The insurance here covers both OPD and IP. Insurance come the kind of population age which is there. Here it's mostly a young population. And since it's also insured for the OPD, the number is 60 is OPD, 40 is IP, which is very abnormal when we look at India where it may be 80-20 ratio, IP to OP. And one of the other challenges, doctors don't want to do complicated cases here. Government is working on it, but then it's again a legal issue and there are a lot of penalties in case things go wrong. So that's also a very key challenge. So overall, on a net basis, it's a very good investment destination. A lot of investments are coming in, but it's a place, you can't earn quick money. You need to be entrenched into this region to gain money. If you are looking at a short-term opportunity, it's not the place to be in. It has its own ups and downs. It has a lot of economic cycle here. So you need to be entrenched to get the fruits out of the investment, what you do here. Now, coming to your second question, which was during the pandemic, right? Rightly said, uh, Dubai was a little bit different. UAE was a little bit different to India because the way government handled the pandemic here was quite different to how it was handled in India. Having said that, yeah, India had a different level of population and complexities compared to UAE, which has very less population. But overall management was quite better from the government end. And it had a lot of private sector support with great coordination. So one thing, the how we managed, but the outcome was 2020 numbers both on top line and bottom line was better than 2019, which was never expected when pandemic came, but that was the result. Now we did many things to get to that, and those learnings we need to carry it forward for the future because whatever we did were not tested at any point of time, and those things succeeded, and hence we were able to achieve what we achieved. Like on the revenue maximization, what we did was we made our modular hospital capacities was increased. We say we were having 200 beds, we made it to 400 beds, right? We created new revenue streams of COVID testing. We had drive-through, we had telemedicines which came through, right? So this started off to pay benefits. The whatever was a reduction in terms of the elective surgeries, we were able to compensate out of these numbers. Secondly, during this period, the relationship with the payer was very important because there were a lot of pressures on the rejections because it's an insurance-driven market and on the patient. So that also was to be managed to minimize the losses. Similarly, on the patient side was also important because connect with the patient cannot go. So we ensured whoever were our patients, etc., the full connect was there through various channels. And second thing, which was accordingly, we had a digital push and we are going ahead with many things because now post-COVID, this is the way we need to go. This robotics has come a big way in the Middle East. A lot of companies have implemented robotics in our healthcare and also robotics, which is in terms of process orientation, etc. Wearables, we have created a program on wearables, which is all the patients who are there, we have given them devices, can be tracked. We have a coordinator who monitors them. So it's a very good connect which has come through. Telemedicine, teleradiology, remote ICU that Harish talked about also is the future, and we have already started on it. And investment onto analytics and good first-class healthcare systems, which is HIS and ERP, is very important. So that there is no way you can now stop it. Everyone needs to go in for it. Because whatever be it, this is, if we get the right systems in place, we can manage the cost very well. Cash flow management was very important, and equally the cost management was there, which is we had implemented a robust costing systems, and supply chain was fully revamped during this period, and manpower efficiencies were built in. Now, manpower was one thing I can tell you, we didn't fire a single employee during the COVID, right? Many people did. We neither reduced the salaries, neither we fired any employee during the COVID. And even we achieved the bottom line. It was based on multiple things what we did in terms of how to use the manpower during the COVID scenario. Right. And based on that, since we managed the COVID very well, our expansion plans, which were there pre-COVID, still expansion is ongoing. There is no delay in what we are expanding. And even we are working on new projects, which were not there before COVID, but post-COVID, we have taken up those projects and we are able to grow further. So the base what to in the post-COVID scenario is we need to be very agile and flexible in our approach. And we need to monitor things very closely, internal, because things are changing every day and day out. So whatever are the learnings of COVID, plus our flexible approach will really support to sustain ourselves in the future. And the result is our expansion is, you can see, in 2021, we are opening one hospital in Egypt. We are opening 2 hospitals in 2022. We are opening 1 hospital in 2022 in Zaneta, 1 in Jeddah, and then we are opening up in Pakistan and Oman also. So these are things which have helped us, and we continue in our expansion plan. Thank you so much.
Right. Right, sir. Thank you so much. Very pertinent lessons to take away from there. Despite being a tough market to operate in the Middle East, you have, really put into place various aspects, various ways of coming through it. In fact, there are expansion plans. And as you said, if you have the right systems in place, there is no way that you cannot deal with the challenge. Our next panelist I would like to call upon is Mr. Sameer Agarwal. Mr. Agarwal is the Group Financial Officer at Manipal Health Enterprises Private Limited, which is an integrated corporate multi-specialty hospital chain owning and managing more than 7,000 beds post-acquisition of Columbia Asia and Vikram Hospitals. It has become the second largest in India that provides healthcare from the smallest to the most complex medical problems. With 27 hospitals in 14 locations, the company is spread across 10 states in India. Mr. Agarwal is a chartered accountant by qualification and comes with over 25 years of experience across diverse functions, including strategic, operations, finance, treasury, mergers and acquisitions, and more. He has worked in diverse industries like FMCG, industrial, healthcare. Mr. Agarwal has also worked in leading MNC and Indian organizations like Wipro, Marico, Coca-Cola, 3M India, etc. Welcome, sir. I would like to ask you, Manipal has done a lot of mergers and acquisitions with an eye on expansion at a time when most other hospitals were cutting down on costs. So that is like looking at COVID-19 as an opportunity, not just as a concern. Could you please share your experience and learnings so far and share the optimism with which you have handled the crisis? Thank you.
Thank you, Pooja. And first and for all, good afternoon and good evening to all the people who are on the webinar. Thanks, Week, for organizing, and thank you for calling us to this panel. Already heard Dr. Hari Prasad, Harish, and even Devendra talk about the various aspects of COVID and healthcare. What I will try to do in the next 10 minutes is maybe add something more on what Manipal has done during this time. Before that, I would just like to just give a brief introduction about Manipal. As Pooja rightly said, that during this pandemic, everybody was on cost, and to be honest, we also looked at costs by line item. But along with the promoters and our investors that are there on the board, we were continuously laser focused on the future as well. We knew that India is underpenetrated. As you know, one of the charts that Devendra showed, that India has only 0.5 beds per thousand population. The healthcare spends in the country is only 1.3%, and most of the spends and most of the investments in healthcare in the country is made by private investors. And hence, we were always focused on the future. And as you see, Manipal Hospital is not Manipal Hospitals anymore. We are Manipal Hospitals plus Columbia Asia, and plus we have recently concluded a transaction on Vikram Hospitals in Bangalore. We very soon will unveil our new logo. I'm unable to share it with the audience because we're still in the works, and we will launch it at an appropriate time. Now, what are we? Post-acquisition, we have become 27 hospitals, 22 owned, and we manage 5 teaching hospitals. We are more than 7,000 beds in the country, which makes us the second largest healthcare player in the country. We also have a joint venture for health map diagnostics. So we have more than 50 labs. We treat more than 5 million patients walking through our doors, out of which 2 million plus patients are new visits. But we continue on our core values of clinical excellence, patient centricity, and ethical practices. This is what we are known for. We are one of those hospitals which are known by the brand, and every patient that walks through the doors of Manipal can assure themselves of the same treatment that they get across all the hospitals that we have in the country. This is where we are as a country. This is the map of India, and as you can see that we were largely south driven initially. But now we have access to markets in the east. In Calcutta, we have presence in the north. Now we have a cluster of hospitals in Jaipur, in Delhi, in Patiala, in Punjab. We are there in the west, in Pune, Goa. But you can still see that there is some vacant spaces for us, which we are currently focusing on. So it's not only acquisition, we are also looking at some acquisition to happen in the east part of the country, and maybe to the center part of the country. So it's not a done deal. Manipal is expected to close on some few more transactions as we go ahead. What were pre-COVID? We were 15 hospitals in 6 states and 8 cities. And you can see in post-COVID, we have become the second largest healthcare. So, COVID provided us the opportunity, in fact, to, increase the speed on some of this. It's amazing the way, things happened during COVID. Initially, in the first lockdown, as everybody said on the panel, we were more concerned about, surviving, keeping everyone safe. We spent a lot of money on our employees. People who got infected were treated free in our hospitals. We spent a lot of money in PPE equipment, imported them. We did not, as Devendra said, he did it in his organization. We did not cut any salaries of nurses. We did buckle down on some costs, but we did not reduce any salaries. In fact, as the pandemic sort of waned, we rolled out our increments in H2 in October last year, and we have given increments in April this year. So what we have seen is, as we engaged with the employees actually stretched their way, which made things possible. Our manpower to bed ratio remained very, very competitively low, which means that less was spent and more was given. And that's one of the biggest learning we had, is if you engage and have open communication with the employees and take care of them, they take care of you. And that was really the ethos in which Manipal survived the COVID, and not only survived, we grew. Along with the acquisitions, we are actually already in the process of constructing 3 hospitals, 1 in Pune and 2 in Bangalore. So this actually will take our further count. It will take a couple of years, but that will take our number of hospitals count even higher. What did we do in COVID, and what made us, expand and, drive efficiencies? There was a huge culture change. As somebody, even Devendra and even, our other panelists mentioned about, digital adoption. Everybody was talking about digital transformation maybe 3-4 years ago, even before demonetization sort of hit India. But what happened during this COVID was the adoption of digital transformation. And it has really changed the entire landscape of the way the business and healthcare is delivered now in the country. Because one is the regulations came through. Initially, the hospitals could not do teleconsultation, and then the bill was passed and the teleconsultation happened. Along with the teleconsultation, there has been a huge digital transformation that has happened in the company. I will just take the audience and everyone on the panel through some of the slides or some of the things that we are doing. I may skip through a little fast, but if anybody has any questions towards the end, we can take it up. Basically, we had the pillars. We created our own mobile, patient mobile app. As we started seeing that the patients are not coming to the hospitals and they wanted to do consultations from the comfort of their home, we got an integrated mobile app, made, which had a video call facility, which had all the, in fact, the entire family could be added to that mobile app, so that at one point in time, the head of the family can see all the patients, all his family together. We started pushing the digital marketing. So this was a huge shift from hoardings and print media to search engine optimizations and social media marketing on various platforms. And now that has become the norm of life. No longer do we see hoardings come up. No longer we see huge print media come up, and everything has shifted to digital marketing. This has made life of finance guys, CFOs, who are also business partners easier, because you can see direct ROI. You can directly see patients looking at it, coming through it. This is the generation which is totally on mobile app. There are more than 500 mobile, phones in India, and everyone has thanks to Jio and everyone has a internet connection. So that has made life very easy. So this is how our integrated mobile app looks like. Registration, appointment, video consult, everything happening together. See, this is what we exactly saw during a search engine optimizations. From a very, very small number, it has actually become more than 5 times. A lot of work is happening around social media marketing. There was a lot of violence against the doctors, which we highly condemn, which is unfortunate. But now you've started seeing that the people have started viewing it. There's a lot more respect for healthcare professionals in the country, especially after wave 1 and wave 2, which was actually a very, very platforming thing for the people. The rich or the poor, the money did not matter. People did not get beds and people were dying. So everyone, I think, so the human community has bonded very well. Everybody is out to help each other. And hence you can see a lot of marketing now getting shifted to social media marketing. Not only give messages, but it actually holds very good messages for the future and how one should behave. We were awarded, and Manipal got a lot of awards for our digital marketing and social media marketing efforts that happened. All this is, why am I showing all this? All this has actually ensured that the revenue stream kept flowing in. Patients felt comfortable coming to Manipal. The brand building continued to happen, and people knew. In fact, what we have started seeing a trend is a lot of the people from the smaller hospitals or nursing homes have started now putting more faith in the bigger hospitals. Initially, there was a lot of negative publicity around private healthcare in the country, wherein about bloated bills and etc. But there's a lot more transparency. And Manipal led the way in that transparency with the patients. Clinicals connected very well. Initially, we had to take our clinicians out to various parts of the country so that the patients can come through from various parts of the country to our referral hospitals in Bangalore and Delhi. But what happened and what changed to the digital is webinars started happening. Clinicians were able to reach out to the patients and engage with the patients. There was a huge patient engagement that happened through the digital mediums. Being a CFO, I don't want to give up just the business. I just wanted to know something that we as a finance team sort of did, and we had totally transformed, our finance function into a digitally finance function. We started this journey quite a long back, named as Project Dishti. But what came to the fore is during the pandemic, we actually, the entire finance function and the accounts payable is fully integrated using the robotic process automation. This has not only reduced our manpower, we didn't let anybody go, we did not just fill up vacancies. It is done by half the people, but the level of accuracy and the level of centralization that we have been able to achieve felt the need during the pandemic when there was a lot of need for conserving cash and looking at working capital. If this saved several crores of money in interest just by having the central process, and all this processing was done at the home of the employees. We had a dynamic capital allocation tool that we built in, and it was all in-house, which ensured that the real capital capex is a very big expenditure. Typically in India, roughly 5 to 6 lakh rupees per bed is spent on maintenance capex, and that's a huge medical cash outflow. In this pandemic, one of the lessons was clearly learned is sales is vanity, profit is sanity, but the real cash is the king. And this dynamic capital allocation that was again released from my office helped everyone to understand what they are really looking at, what is the real priority. Now, even when the businesses actually now come back, people still stick to this capital allocation. So it's very important for us to put discipline in the system, which really came through post-COVID. We managed all the funds centrally. This again helped us. We in India initially, when we kept on buying hospitals and keep up setting hospitals, a lot of the bank accounts were all over the place. So we have 74 bank accounts, but we quickly mitigated and ensured that all the money flows into the HO account. This also helped us manage working capital extremely well, where everybody got the payments in time, but it also helped us monitor the inflows and outflows of the company. And last but not the least, we did the supply chain and cost optimization. This is again one area that I would request every audience to go renegotiate. There is always a best-in-class practice. This activity we do at least 3 times a year, and we have not passed on any cost increases, and we have been able to reduce the cost of delivery. This has really helped us during this time. And again, the finance working along with the supply chain happened due to the centralization that we did with the accounts table. So this has led to great benefits. You can see some of the reduction in cost that we have been able to achieve. But having said that, we cannot take our eyes off compliance. And actually, we were laser focused on compliance. There are more than 65 laws in the country that the hospitals have to fulfill. We have actually automated our entire compliance tool using Complace. Everybody loads in, and hence, even though there were lockdowns and people could not come, we did not have a single event of a default on our compliance. All this has actually led to huge brand building for the hospital Manipal. We were able to close on transactions. We actually closed on Columbia Asia of 11 hospitals. We did Vikram. We actually divested a hospital in Manipal, and all this was done in the last 5 to 6 months. So we believe that if you have the systems and processes and the people in place, and you can look to the future and protect your present, healthcare will continue to grow 15 to 20% in India, considering the current thing. So with that, that's all. Thank you very much. You have there in case if anybody has any questions. With that, over to Pooja. Thank you.
Right. Thank you. Thank you, sir. It was indeed quite interesting to know, as you said, Manipal not only survived, but it grew. And the way it grew in the last 5 to 6 months is incredible, both with the use of technology and by putting systems, processes, and people in place. Great learning there. Thank you, Mr. Agarwal. I now invite Commander Navneet Bali, who is the director of the Northern Region of Narayana Health, to join us. Commander Bali has completed his Master's in Finance from NIFM and his BSc from Jawaharlal Nehru University in Delhi. He has also done his financial cum administrative management, inventory control, and working capital management from Edinburgh Business School in Scotland. Prior to joining Narayana Health, he was associated with IOSPL Cancer Therapy Centers as Group COO and Head of Business. Before venturing into the healthcare industry, he served the Indian Navy for almost 30 years. Yes, for almost 30 years, he served the Indian Navy. In his current role in Narayana Health, he is responsible for overall strategic planning, operations management, service excellence, and business development of the Northern region. His unique achievement, there is one more unique achievement, which also includes being in the Healthcare Council of both ASSOCHAM and CII, Confederation of Indian Industry. He is also on the board of a healthcare AI ML-based platform, Medi. Welcome, sir. So I will divide my questions into 3 parts for you to please answer. And I will tell you all 3 parts now so that you could take us through them. My first question will be, almost as in, although Narayana Healthcare is known for its affordable healthcare, there must have been many expenses which could not have been avoided during the pandemic. In such a situation, what did NH do? Did it compromise on something so that the costs are under control? That is one. Second is, you did vaccination at cost price across India, which is tremendous. So please throw a light on that as well. And the third is, how will you continue to give affordable quality healthcare in the post-pandemic world? That's it. Over to you, sir. Thank you.
Thank you so much, Pooja. And I thank at the outset, Week and Medi Q Healthcare. I think when Latesh spoke to me about this lovely webinar, it was a great opportunity for me to interact with everyone who is present here, both as the panelist and as the audience. Also, I think we both are the last batsmen now, as Dr. Hari Prasad was speaking about, that he is the opening batsman. So it's now left to me and Latesh to really take the match forward. Anyway, coming directly to your questions, Pooja, I think Narayana Health was started by Dr. Devi Shetty in 2000, and it was known as Narayana Hirdayalaya. I think everyone knows about this wonderful institution.
Yes.
He started this great company with, one vision in his mind, and that was to democratize healthcare. It was never started as a business per se. And when I mean by democratizing healthcare, it meant that whether you are a daily wage earner or you are a millionaire, the treatment or the medical, quality treatment that you get should be exactly same. So that was the vision which he came, and we all are aware that I think Narayana Hirdayalaya and now Narayana Health made cardiac surgeries almost, affordable to every person in India, whatever economic strata you came from. So with that vision, when we started, I know, so it was very important to us that the principles and the philosophies of Narayana Healthcare were built around affordability, at the same time quality healthcare. Narayana Healthcare has never ever been found wanting as far as the quality was concerned. It was like boarding an aircraft and sitting in the business class or in the economic class. I mean, you don't, foresee a different kind of landing for the business class passengers or the economic class passengers. You think the same way. Exactly the same way the surgeons in the hospital, the other doctors in the hospital were least bothered about what economic strata that you came from. They were only bothered about, giving the quality healthcare. So let's now talk about pandemic. I think that's what we have been talking about. And I'll also talk about the post-pandemic as you asked the third question, because that's what is the topic today. During the pandemic, I think it was very clear, Pooja, that we were least bothered about anything else but, providing affordable healthcare to our people. We were there only for one reason during the pandemic, and that was, could we save one more life? Could we admit one more patient? We were very well aware of the lockdowns. We were very well aware the economic condition that the country will go through, about the population. We were aware about the migrants, walking thousands of miles from one place to another. We were aware about job losses. We were aware of all that. And conscious call was taken that, listen, this is not the time to do anything but to serve the people. It was very clear in our minds. So, as you rightly said, a pandemic also ensued that you had to spend huge amount of money in PPEs, in protecting your doctors, in your nurses, your healthcare staff. Then came the vaccination, and all that was happening. So obviously the costs, and then you were testing your people, you're testing your doctors and nurses again and again, because the moment someone showed us symptoms, you had to get an RT-PCR done, and only then you could put them back on duty when the RT-PCR came negative. And similar was the case with all the patients and attendants and all that. So we saw a huge amount of cost built up, because it was mandatory for us to keep our healthcare workers safe, but that then gave them so much more confidence in going ahead and doing the job. So this conscious decision was taken that at this moment, as we are going through the pandemic, we are not bothered right now about profitability or about margins or whatever it is. And it came from the ethos of Dr. Shetty or whatever he did. And that's what keeps Narayana Health as a very unique organization when you look at it. And that's why it gives it the most respectable character, not only in India, but we have also one hospital in Cayman Islands, and we operate it at a fantastic way. And it's a very successful hospital manned by Indians in Cayman Islands. Now, coming to your part, so the answer to the first question was, at that point of the time, it was only one thing in our mind, that we were least bothered about margins. We were much bothered about giving quality care to across across people. And as I said, we knew about the job losses and things like that, and we were helping many people at that point of time we didn't bother if the person had money or did not have the money. We wanted to treat people. Coming to the second part about the vaccination, I think Dr. Shetty took this very beautiful and I would say a wonderful decision that if we had to vaccinate the country at a maximum pace, and you're aware, I mean, the private healthcare and government are shouldering this responsibility and going in and doing it. So the government obviously made vaccination free, and private healthcare was given an option of charging what they could because they were procuring the vaccine at a particular cost, and there were a huge amount of overheads. So we took a call again once more that we are not going to charge any service fees across for any vaccine. And so we were doing Covishield at 630 rupees or 650 rupees. The cost was exactly the same. Sputnik, the cost was 998 rupees. We are doing it 1,000 rupees. And we are continuing that from the day one until today. Again, the idea was very simple, Pooja, that in addition to what the government was doing, here was an opportunity for Narayana Health to shoulder that responsibility, keep the costs as low as possible. You can imagine if a family of 4 has to take a Sputnik vaccine, which is around 2,000 rupees in the market, costs them 8,000 rupees. They can take both the doses in the cost that Narayana Health was, offering them. And so we were very, very clear in our mind that vaccination again was not a place where we wanted to make margins or we wanted to make profits. We wanted to give to the public, as low cost as possible. And that was the cost which was that we bought the vaccine at. So that was also a sort of a policy decision taken, keeping in line with what our philosophies, what our ethos, and it has given tremendous amount of response because a lot of people who could not go find places in the government sector to go and get vaccinated or found Narayana Health hospitals closer to their vicinities came to the hospital and got vaccinated. Not only that, along with good NGOs and Narayana Health itself, along with some friends, good companies, we started this scheme of get one, give one vaccine. That means all affordable people could come to NH and give the cost of one vaccine to an NGO, and that NGO we partnered Give India, and we gave free vaccines to people. In fact, we have been vaccinating many people now free of cost who could not go to the government panels again. So again, a very, very different kind of an approach that we took. Thankfully, I mean, we are seeing that pandemic is on the wane now. We are seeing green shoots appearing. We are seeing occupancies of hospitals going up. And as the topic is that how do you give affordable care post-pandemic? So Pooja, affordability is a measure of a person's economic condition. For a person who drives a Mercedes, and affordability is something different. A person who walks to work, affordability is different. So I think healthcare is basically based on the concept where you are able to somehow pass on the benefits that you have accrued from people who can afford to those who cannot afford. It is a simple mathematics. So we went on that principle again. And because of the great amount of, respectability and the great amount of, trust which was and which has been developed over the last 10 years over Narayana Health, and people believe that in spite of being affordable and in spite of being optimal cost, the clinical care is top of the line. So a lot of people who could afford came to our hospitals, and using that, we cross-subsidized a lot of poor patients. We cross-subsidized a lot of patients who cannot afford. So I think I would go on to say that for NH, this is an ethos. This is a philosophy which is inbuilt in the culture of the organization. So it does not take much effort for us to continue to do so as the pandemic weans off. Obviously, as Sameer was talking about, Dr. Hari Prasad and everyone has talked about, that we need to look at the P&Ls. We need to make our systems, processes, people more and more efficient, more and more productive. We need to look at costs. If you look at the P&L of a typical healthcare, or a hospital, the consumption of the drugs, consumables, and implants forms a very, very important part, which Sameer was also mentioning about, which is called the supply chain. So if tightening those things does not hurt anyone, and Narayana Health has been known to sort of negotiate with large vendors to bring the costs down, to talk to doctors about can we bring the consumption down. We spoke to many doctors when this oxygen thing came about. Could we tweak the settings on the ventilators, which gave optimal oxygen to the patients? At the same time, we were cutting costs but keeping the quality healthcare the same. So in the end, Pooja, I would only say that since this was inbuilt from 2000, and we've been practicing this over and over again to provide quality healthcare at affordable costs, it did not come to us, when the pandemic stuck in anything different. We continue on the path. Yes, We are using technology in a big way. That's Dr. Shetty's dream. A doctor today can take an ICU rounds on the Adi app on his mobile phone sitting at home. We are making our processes more and more efficient. We are making our people more and more productive. And, that's how we are still, continuing to be what we are. Thank you so much for inviting me here today, and to all the listeners who are hearing me out patiently. Thank you.
Thank you, sir. You literally took us through the philosophy and ethos of Narayana Health. This is what it stands for: pass on the benefits accrued from those who can afford to those who cannot. And, this is how you all really sailed through the pandemic. I think you all were least bothered. You said about margins, but the most important part was to provide quality care. I think there's a big takeaway from there. Thank you for sharing it, sir. I now invite Ms. Latesh Sen. Welcome, ma'am. She's Group CFO, Medi Q Healthcare Group. A national award winner in healthcare cost management, Ms. Sen is a skilled cost management accountant with a specialization in international finance from IIT Delhi, as well as a Six Sigma expert. She is an expert in designing operational protocols to run in a cost-controlled system with operational and clinical efficiency, revenue cycle transformation, financial reengineering, strategic pricing, and cost optimization. She's credited with developing patient-centric, time-driven, activity-based costing and business efficiency modules in the prominent hospitals across India. She's a strategic brain behind all the verticals of Medi Q Healthcare Group. Welcome, ma'am. And I would ask you to please share, your expertise on. You've been at the forefront of efficient cost management in hospitals, both in India as well as in the UAE. How do you look at the present health crisis, and what do you advise hospitals to take note of, especially in the area of best practices in cost management in the current times? Over to you, ma'am. Ma'am, you are on mute. I think you'll have to unmute yourself. Ma'am, you're on mute. Yes, I think now you can speak.
Thank you, Pooja. Good afternoon, everybody. And it was really wonderful to hear all the prominent speakers, leaders, and their views. It's really enriching all the time. Medi Q got the chance that, Medi Q got a chance to serve the society by operating and managing COVID field hospitals and isolation centers on behalf of Abu Dhabi government. Being part of UAE government disaster management program, we are proud to touch millions of lives. And we are proud that we were appreciated by the government for our efficient and cost-effective operations. Over the last 1.5 years, the pandemic has taken a toll on the healthcare industry. In general, cost has gone up and hospitals suffered a lot with the society. As a cost strategist in the healthcare with over 2 decades, I can safely say that this is not a novel situation. Sudden surge in cost in the industry has happened before. Change in government policies as price capping in stents, ortho implants, revenue capping by GIPSA packages, CGHS packages in India, and now DRG pricing in UAE. That has all put adverse effects on the healthcare, on the revenues. So ultimately, the whole burden lies on the cost to make the bottom line corrective. As experienced healthcare leaders, we all know that driving in revenue, even when the best of sales and management marketing plans are implemented, it's a slow process, and it depends too much on the market dynamics. And especially after the COVID, lot of resegmentation and fragmentation of the patient and the care demands has done. So maintaining the bottom line by excising cost control is way more easier exercise, but if done scientifically. It is important to understand that COVID is here to stay for much longer than we initially anticipated. And our leaders have already done the research on that, and it is evident. So the immediate step is to devise strategies that keep the cost of care under control to constant changing situations. Basically, still we are under very volatile world that we still don't know where the logics, where the cost of care, where the hospitals will go. So COVID accelerated us towards the digital era. Samir Manipal is doing great, and Samir also mentioned that new innovations and advanced technologies is going to play a major role in now new healthcare management of the society. Here, the role of CFOs and CIOs have become more strategic than ever. Now, the operations and finance have to look at all the perspective and strategy in a new perspective. For me, it had been a fulfilling journey apart across the globe in my scientific cost management. And I have worked very long in very prominent healthcare where the cost analysis was just being introduced long back. And but India and UAE, they are still very far behind in adopting the scientific cost management. I remember the struggle we were doing along with the platforms like IM and CII. Navneet, you must be remembering, you were sharing with that platform with me, when we were struggling with the government agencies to convince them that cost of procedure should become the basis of pricing for Ayushman Bharat or any other government policies. So still there is a long way to establish the right cost practices. Disturbance from COVID is still not settled, but now challenges lead us to new strategies. Some new philosophies have to be adopted. And let me share a few examples and techniques we used across different hospitals in different situations. But these are the basic philosophies. Techniques are there, methods are there, but everybody has to adopt some new philosophies the way they have to be done. The first thing is knowledge sharing. Why we are having this webinar and we encouraged this webinar and we became the knowledge partner with Beak is because if we are sitting in our own geography, then we will have the benefit of that geography only. We will not be able to adopt the new things. So healthcare spend and behavior is slightly different in different geographies. Healthcare providers, I believe, should learn the best practices from each other. For example, UAE has the limitation of labor contracts, resulting in very high manpower cost. Devinder has already mentioned that, and they're struggling with that also. Whereas India has an advantage on it. So the UAE health system must analyze their physician contracts and outsourcing the facilities for better utilization of their resources. COVID created more acceptability of distant work culture and telemedicine, so we can take benefit out of that. Whereas on the other hand, UAE has advantage over India in better accessibility of global techniques and innovations. Global workforce in UAE provide a very diversified culture and very unique approach. So healthcare providers can adopt the best practices for different geographies with a little shift as per their local laws and opportunities. But how to do that? For that, we must reevaluate ourselves. I can just share one thing, that is Kaizen costing. Kaizen is a Japanese word. It means constant improvement without past data, with zero pace. So here we do not refer the past cost data, but we across each activity, we assess as a new process. Sometimes we are so much engrossed in benchmarking that we do not create a new path. To begin with, we need to assess each cost element as at a scratch in short term as well as long term. We have witnessed a major disruption in supply chain due to this COVID in logistics, transportations, and availability. But every challenge comes with an opportunity. We started looking at alternative markets, alternative products. And I'm sure most of the hospitals must be doing a lot of analysis and renegotiations to keep their pharmacy and consumable cost into control. We also did a project with a very high-end hospitals here and a lot of purchase heads. We help them and handhold them with their vendor management by reviewing their vendor contract and suggesting them the area of renegotiation to adopt the uncertainty of future operations. So in short, out of box thinking is required. No other ways can work now. So for that, I believe give your organization a third eye view. When I call it a third eye view, what does that mean? Everybody is expert, I know, and everybody knows, but nobody knows all. I just want to share that there is a story that was roaming around on the internet, and I also read that, and it was very interesting, that a group of people were shown a game on the screen where ball was passing around at a very fast pace. So they were told to count the passes by certain people. During the game, there was a man wearing a gorilla outfit. He was roaming around, passing, thumping his chest. After the game, behold, when people were asked if they saw the gorilla, most of them convincingly denied it. Was that they did not see it? No, it's not the eyes, it's their brain that tricked them. This is an actual experiment. The scientists even got the Nobel Prize for that. The automatic brain pattern gets leaders and managers to miss out on the obvious all the times. This is a proven fact that when you are expert of a process, you're habitual of a standard pattern. And sometimes you may miss very obvious flaws. The review by a different source might show scope of improvement. Believe me, creating a cross-functional team can be a path breaker. So look at expenses from a distance, from a different angle, and you can really find a good cost opportunity, saving opportunities. Though we are in healthcare, so I must say, diagnose before treatment. That is the crux and that is the base of our healthcare industry. What cannot be diagnosed cannot be treated. And it goes very well with the financial health of the organizations. Please do not do cost control. Please do not do cost reduction. Please do waste control. Please do waste reductions. Accurate diagnosis of area and process of wastage is very essential. The spend analysis is the secret behind identifying the cost saving opportunities. Our team analyzed the cost of efforts against each and every line item of the patient invoice. As Dr. Hariprasad rightly said, that Apollo and all the everybody is doing, and Apollo has adopted it very well, that they are going for line-wise cost analysis. So same thing, we generally use various methods for the scientific costing, but mostly rely, and that is my favorite, is the time-driven activity-based costing technique, in which our team just complete organization is evolved and we do the per patient cost with accuracy of direct and indirect fixed cost allocations. So take your data-driven course of action. But last not the least, don't ignore your support cost. Support departments that are very tiny departments, and generally we tend to forget their efficiencies and their associated costs. Generally, hospitals are too focused on the consolidated cost of pharmacy, consumable, manpower, doctor, nurses, because that constitute almost 50% of the total hospital cost. But during this, they generally forget the CSSD, laundry, maintenance, chillers. Mostly we convince ourselves that saving is only meaningful if there is some large outcome. But the fact is that improvising small processes or doing away with the minor cost is not notable in short term, but it can be just as meaningful, especially in the long run. But for setting the targets, accuracy of business rules, that is very important. If input is correct, then your output is correct. For example, if you want to control your electricity cost, what would you do? Either you benchmark it with your past consumption or the industry standards. Okay, you have done it. Now you know that it's high. Then how will you diagnose the culprit? How will you know that what should have been the standard cost for a particular department? For that, you will allocate the cost to different departments on the basis something like area. But will it give you true picture? Because actual consumption cannot be directly related to one factor. It depends upon area covered, temperature monitored, hours of operations, equipment use, stay of patient, and many more. So suitable weightage to each cost factor, each reliable factor is very important. So please do the costing properly and set your targets very carefully. This is what my suggestion to all my peers. And thank you so much. Thank you, Pooja.
Right, ma'am. Thank you so much for throwing insight on that. What we need, I'm sure, is out of the box thinking, as you said, a third eye view, as well as don't do waste reduction and not cost reduction. I think that's a very, very important point you made out there, which is a key takeaway again. Thank you, ma'am. I think we will now open the webinar for audience questions, of which we have quite a few here. Let's begin with the first one. I think it comes from Mr. Rajiv Vasudevan. He is the founder CEO of Ayurveda Hospitals. So Mr. Rajiv asks, many American and European centers of medical excellence have adopted integrative medicine as a key complementary component of their health services. What do the speakers feel about the immediate prospects for such models to emerge in India with Ayurveda appropriately integrated into their care model? So basically, he wants to talk about how Ayurveda will be integrated into their care model. Can I open it for Dr. Hari Prasad? Would you like to take up that question, please?
I lost you in the middle. Can you repeat the question?
Yes, I will. So he is asking if he's saying many American, European centers of medical excellence have adopted integrative medicine as a key complementary component of their health services. What do you feel about the immediate prospects for such models to emerge in India?
Actually, you already have existing models in India. Integrated healthcare is the ideal model because health requirements are not isolated either to primary, secondary, or tertiary care. It's a combination, and an individual could need any form of any level of care that is required. So integrated healthcare is a very important model, and it is already available in India. Multiple players are already, like for example, Apollo has all primary, secondary, and tertiary care facilities. And then now we have the digital platform to integrate all the physical platforms together. So that is a huge addition. And now we have, again, if you take the Apollo's example, we have the app called 24/7, which takes you to any part of healthcare that you may require. You can buy medicines, you can order tests, you can book appointments, you can have a teleconsultation, you can actually see your patient in the ICU. So that is actually created in true integration. Now the digital platforms have created true integration. And I think that is the road ahead for healthcare. And the future of healthcare is going to change significantly. And because newer models of care are now coming into place. Now you have home healthcare coming in, you have daycare surgeries coming in with the better improvement in technology, improvement in skill sets of the providers are helping, and improvement in technology is bringing in new models of care. And the secret behind adopting these new models of care is to integrate them all into one platform and so that an individual is able to pick up what is right or what is appropriate or what is required for him. Does that answer your question, Deepa?
Yes, yes, sir, it does. Thank you for that. We have many questions, but I do not think we may have the time to take up all the questions. But in case we cannot, then I will request all the panelists to, we can send the questions to them via email and they could answer them. Right, I think we will take one more question. This could be answered by Latesh ma'am. Ma'am, tell us, there is a question that says, please tell us in what ways can hospitals tackle the cost crisis with help of technology and artificial intelligence? Ma'am, would you like to take that on, please?
Yeah, sure, Pooja. Definitely, technologies has evolved to support in efficient cost management, and COVID has encouraged new innovations on digital platform. Usage of artificial intelligence will definitely help understand the treatment variability and cost modeling while eliminating the waste in the system. And USA and some other developed countries were using the cost management softwares from decades. And we were jubilant that at the discovery that the cost management software was the answer to all the problems. But strangely, we realized that a standard software or a standard set of rules were not going to stand good, as each hospital and setup requires almost 60 to 70% redefining of their business rules.
Right.
It would require constant reviewing as well. So the operations and hospitals are not as agile as an Excel sheet. So human intelligence and analysis is equally important with the use of technology. Our cost experts have implemented the cost system and the softwares with large number of hospitals across the globe. But the software and automations does not suffice the problem of cost management. That is just a tool. A deep analysis and teamwork is must. And it is essential that any strategy we take, it should be backed by data. So technology and human intelligence should go way to way.
Right. Thank you so much for that, ma'am. Just one more question. I would like to put across to our panelists, because many from the audience have asked this one: how standalone hospitals can manage, post-COVID, because it's really difficult for them to sustain. So they want to know how can they manage. So who would?
I will just take that up, even
Sure.
though we are a we have lots of hospitals, but when we took over Vikram, Vikram was a standalone hospital, only one in Bangalore, and was profitable. So even during the COVID times, they were profitable. They had a lot of, so again, as what Latesh and what everyone on the panel has said, it is to look at cost line items, be aware what the model is, and then have manpower according to it. For example, if you have a 150 bed hospital, but your occupancy is around 50, so you have manpower around, maybe 10-20 beds over that. So you can always add manpower, but you can look at how can you make your manpower to bed ratio more competent to ensure that you're delivering the healthcare, but also not overstaffing. You look at waste management, as what Latesh said, is that is, again, for example, things like departmental consumption. This comes up, very often, where a lot of gloves and everything get used. I think so. NH also does a great job of bundling the consumption that has to be used for a procedure and then given. We also do that, and I've seen a lot of standalone hospitals do that, of ensuring that for each procedure, which is a standard procedure, if it's a complicated procedure, it's fine. For a standard procedure like a stent, you have everything defined, so that you can estimate the cost. The patient is also aware of the cost. And the third, but not the least, if you can provide a differentiated service to the patient, which means transparent billing, quality care, as what even Navneet said, that people are ready to pay. India may look like a developing country. I think so. There's enough and more money. If you have seen the Zomato share getting oversubscribed, the healthcare budget of the country was spent on Zomato, listing. So the money is not the issue. Issue is if you can provide quality healthcare, be transparent, be empathetic to the patient, I think so. Even standalone hospitals have done very well during this pandemic because they are the neighborhood hospitals for the patient. So patients feel more comfortable and warm feeling to approach those hospitals. So I think so. That would be my answer.
Right. Latish ma'am, would you like to add to that? Would you like to add to what Samir sir said, please?
No, Samir is very right. This COVID affected not a single geography or single specialty, but as a whole, the complete whole healthcare system. But definitely, Samir, you would agree with me that standalone hospitals and small nursing homes were severely affected. Big hospitals chains have advantage of scale of economy, but on the same page, small hospitals have the benefit of flexibility and speed, which big setups are not having. So they can accommodate themselves. But every hospital, whether it's a single standalone or a chain or trust hospital, not for profit, anywhere, government hospitals, every hospital need to be reviewed in isolation because similar set of solution does not apply to all. Their vendor management is different, their vendor strength is different, their set of rules, business rules, everything is different. Even the manpower and their business rules that are so different. So it is very important to know that how to scrutinize their P&L. How do you analyze that where the waste lies in short term as well as long term? There has to be two philosophies everywhere, that what is your short term goals, what is your long term. And when future is still uncertain, then it becomes more essential that you must complete control, you must keep a complete control over your cost and insulate the cost which are going to bounce back in future. So that is very important. So have a proper control. You must analyze the complete cost strategy. Different hospitals have to adopt different strategy as per their unique geography and unique challenges. That is my suggestion.
Right. Thank you, ma'am. We have Dr. Manisha Danani, who has asked a very interesting question. She asks, how do you see the future of the general practitioner? May I request Commander Bali to take that up? Sir, will you be able to, throw light on that aspect, please?
Yes, absolutely. I feel a return of the general practitioner. I think that's going to happen because, as many of us were talking about, for many such things where a patient does not have to necessarily go into a hospital. I mean, the first line of treatment was always the general practitioner. In fact, the family doctor was a general practitioner. And I actually feel that with pandemic and this fear inside people's hearts, which is going to last for a very long time, the psychological trauma is very strong. People would rather go to a close by general practitioner for initial, small things which they don't have to rush to the hospital. In fact, I would go on to say that chains like us, like NH, we are looking at this integrated healthcare model in which we don't recommend people coming to hospitals rather than going into smaller clinics. In fact, we are thinking of a model where we are going to likely to have, what we call as NH outposts or NH clinics, where people don't have to come to the hospital for small things. They can go into to general practitioners, which will be in these clinics, and then if required, only they come to the hospital. In fact, these general practitioners and their clinics would become a collection center of samples, would become places where they could collect the reports. They could be places where you could do a video consultation. So I think there is a tremendous amount of scope going forward for the GPs.
Right. Thank you, sir.
I just wanted to add one thing.
Yes.
If the audience is that specific party, there are a lot of startups that are actually accumulating and aggregating the GPs. There is a startup called Medi Q. So they have built in small softwares in which they are actually practicing with the GP, managing their pharmacy. So there are a lot of small models and startups that are coming up, which will ensure that the GP practice and the softwares and the pharma is all managed. So I agree with Navneet totally. One is that the GPs are doing business. And again, people who innovate will survive. And if people are going to do the business the same old way, will find it difficult. So that is the end message on this, Pooja. Sorry for taking up more time.
Basically, that's what I was saying. That now philosophy should be changed. Techniques can be there, but philosophy, now we have to think out of box.
Right. True. True. We have one more question that is, by Dr. Selvarajan. He speaks about, as in, he wants to know. He wants a discussion on the aspect of mental health care approach and management. Right. Mr. Singhvi, do you think you would be able to help us answer that, please, with regard to
Sure.
Saudi?
I think the post COVID, this is a very relevant topic because
Right.
a lot of people have gone through stress and difficult moments in their life and journey.
Yes.
So this has been a top priority for most of the healthcare firms worldwide. As a next step, they're ramping up the mental health care, which is we have a psychiatrist, psychology. These departments have been ramped up, uh, and there are a lot of kind of telemedicine is happening on this. Lot of support groups have been created, and hospitals are helping. It's not only the psychiatrists and the other doctors. There is kind of a yoga sessions are been conducted. There is some wellness sessions are happening. So this is kind of an integrated approach. It is what we call is a post COVID rehab, right? Which is because a lot of patients need this. It's not, maybe they have gone through COVID as a disease, or they have experienced some mishappening in their family, in their job, in any part of their life. So we have opened up such center, and that would really help overall as a patient, and many other hospitals have also done in the Middle East.
Right. Right.
Right.
Right. Right. I think with that, we have come to a close of the webinar. We have 10 more questions, 10 to 15, in fact, more questions that are pending, which is great. But however, I think we will email all your questions to the panelists so that they could give you the feedback on your email addresses. Thank you so much. And we have indeed learned a lot of lessons here. I think it's been tremendous success to really, because there have been so many lessons learned, so many aspects that have been highlighted in both during, the way hospitals managed during COVID, as well as future plans post-COVID. I thank each and every one of you for taking time out and attending this webinar today. Thank you, everyone, and thank you for making it a huge success. Thank you once again from
Thank you.
Peak and
Thank
Medi
you
Q
very much.
Healthcare.
All
Stay
of
safe,
you.
guys. Thank you.